Hello, everyone. On behalf of Pentex Medical, I would like to thank you all for joining this live webinar. Just to start with the agenda, so there will be 4 faculties, 2 from India, Dr. Tinku Joseph and Dr. Sushmita Roy Chowdhury, one Dr. Anantham Devanand from Singapore, and one Dr. Pai from Taiwan. So these all faculty will be actually having one lecture each for 20 minutes. Post all the presentations, you will have an open question and answer session, and you can ask your questions. There is a window on the right side, a question tab, and you can ask your questions after the completion of all the presentations. Hello, I would like to begin on with behalf of Pentex Medical. I would like Sushmita Madam's introduction as well as her presentation. Dr. Sushmita, you can please begin.
Epidemiology, pathogenesis, transmission, clinical profile of the patients, how do we diagnose the disease, what is the management, and what complications you can come across, and then we just summarize it all. I've been given only 20 minutes, and so I'll just keep it short. So just to make it clear, I'm from a city called Kolkata, which is a city where you'll find most Bengalis in the best suites. It's also called the City of Joy, and I work in a hospital, private hospital called Apollo Gleneagles Hospital. Okay, so let me start my presentation. So it all started in Wuhan, which wrote the story of the novel virus that plagued the world, even though it's not a bacteria, it's a virus. And the facts that we just need to come across is that the first case was documented on 17th of November, but it was only in December that a whole lot of cases, to be precise, about 59 cases with fever and dry cough were admitted to, Wuhan, and 41 of them were confirmed to be infected with the 2019 coronavirus. So by the end of 2019, nearly about 50,000 of cases were reported from China and mostly from the Hubei province. And the initial epidemiologic investigations led to a seafood and live animals market in Wuhan, where most of the patients had visited either to buy or work or to visit somebody else. And the initial reports that Chinese people gave out was that of the initial 27 people who, from 1st of December until January 1st, 2020, the market was closed. Most of these patients had been to the market there. And most of these patients who got admitted had a very high mortality. Of the 13 patients that were admitted to ICU, of the 41 patients, 15% actually died. Now, of the patients that were admitted, they found that it was males that were in the age of 45 to 59 that were amongst the patients that suffered more badly, and also had comorbidities as diabetes, hypertension, chronic pulmonary diseases as COPD, and other cardiovascular diseases. And interestingly, they found that most of these patients had lymphopenia, the D-dimers were raised, and their liver functions were slightly deranged. After the epidemiologic alert by Wuhan local authorities and the slides that you showed, which were from the initial Chinese hospitals, they were 41 of these 59 patients that initially presented were confirmed by PCR, followed by heavy caseloads in various Chinese cities and provinces, which was linked to the fact that it was the lunar month and there was a lot of transportation happening between the cities. But the first exported case out of China was found in Thailand on January 13. It was reported in Thailand. And World Health Organization issued a public health emergency of international concern only on the 30th of January, which is about a month after all these cases had appeared, and declared it a pandemic only 2 months later, which was in March. Now, chronology of global outbreaks we've talked about. It went on from November, 17th November, as we said, until February. Nearly about 28,276 confirmed cases have been there, with 565 deaths in at least 25 countries involved. And since 31st December, this is early April, these are WHO numbers. Initially, it was China that was highest, but more than 1.5 million people beginning of April have been affected, with nearly about 95,000 deaths reported. And at the current moment, United States of America has left China far behind in morbidity and mortality. Coming to the epidemiology of the virus, the basic reproduction number of the SARS-CoV virus has been estimated at 2.2 and 3.3, which basically means, to simplify it, that each infected individual infects about 2 to 3 new people. But what they also saw, that the case fatality has remained about 3% or so. But it is speculated that it is likely to be lower than that because not all patients infected with SARS-CoV have been tested. Because only these symptomatic ones have been tested in most countries rather than all, just as in for example, South Korea did. The milder cases have not been tested, and hence likely the mortality rate is skewed upwards. What is very clear is the transmissibility factor of this virus is extremely high. And this is how the world's map looks like. The second of April, hardly any country that has been infected so far. So coming to the basis of the virology, it's an enveloped positive standard RNA virus. It's a coronavirus with characteristic crown-like spikes on the surface, and WHO has qualified it as a group B beta coronavirus. And it belongs to the subgroup sarbecoviruses. The exact origin and natural reservoir are unclear, but a lot of it has been linked to zoonotic things like bats, and there is a lot of talk going on about maybe anteaters or pangolins being intermediate reservoirs because a lot of people keep them as pets. But it isn't very clear as to what it is. If there's one slide that you need to take away from what it does and how it comes in, then this is the slide, and that is why this is not my own. I have borrowed it. So SARS-like bat CoVs, as in SARS and MERS-CoVs, as we knew, go on to an intermediate host. We don't know whether it's a domestic animal such as a pangolin. And what is very important is that there needs to be host factors. For example, it has been conjectured or shown that it's the human angiotensin converting enzyme 2 receptor that the S protein and the M protein go and lock onto. And they go on and unleash a significant amount of innate, dysregulated innate immunity that then worsens it. And for the host factors, the human ACE2 receptor is there, and individuals who are more susceptible to severe disease are elderly and people with underlying diseases. And cytopathic effect and cytokine storm or sustained inflammatory responses with hypoxia, septic shock, etc., may be related to the critical conditions of SARS-CoV infected patients, especially in the high-risk category people. So underlying health conditions which have been shown to have high susceptibility are hypertension, COPD, diabetes, and cardiovascular diseases. Now, the main pathogenesis is that it was found to affect mostly the lower respiratory tract infections, causes RNAemia, and then combined with incidence of ground glass opacities, which we'll talk about, and also acute cardiac injury. A lot of patients present with symptoms of myocardial symptoms rather than respiratory symptoms. And all the raised plasma procytokines, etc., are there, and they are reason to promote disease severity. So this is one slide which shows you that a dysregulated or exuberant innate response is a leading contributor to SARS-CoV-mediated pathology, where in an uninfected alveolus, as soon as there is rapid virus replication, there's inflammatory cell infiltration, pro-inflammatory cytokine and chemokine responses, which cause ALI or acute lung injury and respiratory distress syndrome-like features. Although these patients don't exactly behave in a way an ARDS patient of other etiology behaves. Coming to transmission, there's a lot been going on, talks about whether it's aerosol, whether it's droplet, but what's been found for sure that droplets, direct contact or contact with contaminated objects or surfaces, if somebody coughs and there's droplets remaining on a surface, on steel and other subjects, it can stay alive for 8 to 9 hours, and then somebody touches it and then touches their face or their nose, it's considered to be the most common source. Now, whether aerosol remaining in air actually causes a significant amount of transmission or not, there is still doubts about it, but it is thought about. fecal-oral route has not been shown as in the other SARS-CoV infections. Now, symptomatic people, those who are experiencing the symptoms, are the ones that definitely cause significant amount of transmission from one person to the other if you are in contact with them for a certain amount of period of time, such as 5 minutes or so. But during the incubation period of 5 to 6 days, in the pre-symptomatic phase, people still transmit. And in lab-confirmed cases, it has been shown that people who are asymptomatic but are suffering from infection can also transmit the disease. This is quite a nice slide which shows that higher viral loads are detected soon after symptom onset, but there is higher viral load in the nose than in the throat. And it was detected in asymptomatic patients, as I showed to you, in lab-confirmed patients. This is a nice SARS-CoV viral load article in New England Journal of Medicine in February to read that even asymptomatic people are able to transfer, and these are the ones that we are most worried about. Coming to clinical symptoms, the incubation period from infection to symptoms is usually approximately 5.2 days or so. And the most common presenting symptoms are fever, cough. Fatigue is a very important thing. Anosmia is something most people can present with. Sputum, diarrhea, and dyspnea come on later, and characteristically found to target the lower respiratory tract infection, as we said. And this has been taken from the internet about all the range of symptoms that you can have. Usually, though, nasal blockage is not one of the symptoms that patients can present with. Acute cardiac injury, diarrhea, and pneumonia are the common presenting findings. In labs, you usually find lymphopenia with normal or low counts. The procalcitonin levels are normal. And if you do a chest x-ray, there are infiltrates. This is again taken from New England Journal of Medicine. Initially, chest x-ray can be innocuous completely. But as days go by, beyond 5 to 10 days, there are infiltrates that appear, usually bilateral and peripheral. And later on, as one of the patients' x-ray from China, you can see that it is a full-blown ARDS picture on chest x-ray, but it's pretty late by then. However, CT chests are the most sensitive of surrogate investigations you can do while waiting an RT-PCR when a patient presents with particular symptoms. Even in our hospitals, we find CT is extremely sensitive in showing symptoms, such as in the early first 2 days, nearly half of the CTs are normal, but approximately 5 days post-infection, early ground glassing comes in, which goes on to become more confluent, and crazy paving appears in about 5 to 8 days. Consolidations, which are multilobar and peripheral, appear in about 9 to 13 days. About approximately 2 weeks, fibrotic strands and interstitial thickening appears, and overall resolution is seen around 4 weeks' time in most of the patients. For definitive diagnosis, a nasopharyngeal swab or oropharyngeal swab for RT-PCR is the most helpful. It is a highly specific test, but sensitivity can be as low as 60 to 70% and as high as 95 to 97%. A lot of it depends upon the technique by which the nasopharyngeal swab has been taken. False negatives are a problem, so therefore, in high clinical suspicion cases, they may need several repeats. In our cases as well, we have seen where there's high clinical suspicion, the first 2 results have been negative, the third will come, in most cases, will come out positive. And plasma antibodies appear beyond IgM beyond 5 to 7 days and IgG after 2 weeks. This is again a slide taken from one of the patients initially presented to the Chinese hospitals to show that of the 41 patients that were admitted, dyspnea appeared around the 7 to 10 days mark, and then after that ARDS and then intensive care admission around the 12 to 14 day mark happened in most of the patients that were presented. Coming to the management of these patients, it is essentially a supportive care that is important. At the present moment, there is no evidence currently to support any specific antiviral therapy. There's a lot of medications that are there, and every country, I think, follows their own, their own protocols. In our country, we have a lot of protocols. To present one from All India Institute, New Delhi. When a COVID-19 patient presents, we classify them as mild, moderate, and severe. In mild cases, if the patient is tested, and if they are tested, they test negative, they are kept in isolation, they are given symptomatic management alone. If they test positive and still have mild symptoms, they are kept in home isolation and they are given azithromycin if there is evidence of secondary infections, and paracetamol and symptomatic treatment for fever. If they worsen, which is moderate to severe cases, how are they defined as moderate to severe cases? If the respiratory rate is more than 24, saturations are less than 94% in room air, if they're slightly confused or drowsy, and if they are hypotensive, then they are admitted and the test is done. If the test is negative, they're managed and test is again repeated. If at least there have to be 2 tests negative and radiologically no signs to suggest COVID to call them negative. Otherwise, they're kept in hospital and managed. Initially, oxygen is given for patients who are dyspneic or have saturations less than 92%. Antipyretics and antitussives are given for dry cough. And usually, nebulization is avoided in order to reduce aerosol generation. MDI with spacers are preferred. Initially, hydroxychloroquine 400 milligrams BD for day 1 and then 200 milligrams BD for 5 days is what is given. If they continue to worsen, then in India, in most of our hospitals, we use the lopinavir and ritonavir combination, 200 milligrams, 2 tabs twice daily, and monitor these patients. Do not combine hydroxychloroquine with lopinavir. If you're starting ritonavir-lopinavir combination, then you need to stop hydroxychloroquine because of drug interactions. And corticosteroids are to be avoided. If these patients continue to worsen in respiratory failure, hypotensive or multi-organ syndrome, and the PaO to FiO2 ratio is worsening, they are shifted to intensive care. We avoid HFNC and NIV again because of aerosol generating properties, and these patients are electively intubated mostly. Conservative fluid management needs to be done for shock. Standard care for ventilated patient with lung protective ventilation is taken. We try and avoid high PEEPs because it has been seen worldwide that high PEEP patients don't really do very well. Prone ventilation is preferred, and in our hospital as well, we found favorable results from early proning of these patients. And in refractory cases, ECMO may be required. And these patients are discharged when they have 2 negative tests and are symptomatically and clinically stable with normal oxygen saturation levels. There's a lot of talk going about steroids and immune response. At the moment, current evidence does not support early corticosteroid use in mild to moderate COVID-19 without comorbidities. But if you do have a patient who has come in with acute exacerbation of COPD and has significant amount of bronchospasm, you will need to consider steroids in that case. Complications commonly are acute cardiac injury with raised troponin levels. We are finding more and more patients presenting with just these symptoms to begin with. As the disease becomes more severe, the patients can have secondary infections, sepsis, acute kidney injury, and multi-organ dysfunction and multi-organ failure-like syndromes. And in severe ICU patients, a fraction of them will present with secondary HLH syndrome, or a cytokine storm, as they call it. And we find that CRP and ferritin, which are surrogate for IL-6, actually guide you towards it. Now, in 20 minutes, it was difficult to really bring everything down, but I'll just summarize in one slide that COVID-19 is a beta single-stranded RNA coronavirus, which is highly transmissible with still low case fatality rate. A dysregulated or exuberant innate immune response is leading contributor to pathology. The gold standard at the moment for diagnosis is RT-PCR, which is done with a nasopharyngeal or an oropharyngeal swab. The CT findings are quite characteristic and early on with ground glass opacities, crazy paving, peripheral consolidation, and atoll sign or reverse halo sign may be found. And management is mostly supportive with no antivirals as of yet. Thank you very much. I'd like to stop my talk there.
Thank you so much, ma'am. May I request Dr. Pai to please introduce yourself to the attendees?
Hello.
Hi, sir.
Hello, I'm Pai-Chien. I'm come from Taiwan. Now I'm director for Taipei Medical University Hospital from my thoracic department. So today I would like to share some of the perspectives. Can you share my slide? Can you show my? Can you see my slide? Yes, okay. So today I would like to share some of the new perspective on prevention and treatment for COVID-19 pandemic, stress based on Taiwan experience. Okay, I think the previous speaker has discussed some of the details regarding the COVID-19. So I agree that the coronavirus is an RNA virus which composed of different spike protein on the surface. So it will be useful for detection and also for maybe design for vaccination in the future. And I think the statistics are different between individual studies. So maybe the basic productive value is different. The incubation time may be ranging from 2 to maybe 28 days. And the mortality rate is varied according to countries and also to races. The treatment is still under estimation, although someone called it the remdesivir may be possible to treat a patient with the virus inside, but I think we need more evidence to see when to use it and about the dosage, and also whether the drug can penetrate to lung or not. So I think all of you are very familiar with the transmission process. Maybe arises from cough, sneezing, or personal contact. However, some report also mention that because some also mention that maybe the virus can be transmitted from the feces route. So we still have something unknown regarding the transmission of the virus. However, we are still unknown why the COVID-19 virus emerged, because there are so many mutations. So you can see that some articles begin to discuss where does the virus arise from, whether from Wuhan or from the other part of the country. So you can separate the virus origin maybe according to their gene arrangement and separate into several different clusters. However, we still cannot find a distinct location and also a definite virus condition for individual country. And also, I think all of you have seen this journal before because...
excuse me, Dr. Zhou, could you turn off the screen, because the screen have something they just cover your slide. So could you just delete?
Okay.
荧幕有一个，对，okay.
Okay. Sorry.
Okay.
Because from it's okay now?
Yeah, sure. Thank you.
Okay. Sorry. Yes. Because the virus are mutated due to its RNA in origin. So with each replication, it will change some of the gene arrangement. So this interesting paper indicates that the virus can be separated into different groups according to the gene arrangement. However, the impact of the virus gene and also the severity of disease is still not limited to the virus itself, but maybe due to the individual immune status, which will impair the defense to virus and to the treatment for disease. So now we are looking into possible biomarkers for virus treatment. So if the patient can survive the virus attack, we can see that the D-dimer are low, and also the lymphocytes are kept in a high level. And the interleukin-6 is low in those who survive the virus attack. And also the lactate dehydrogenase, you can see that it's very low if it can survive the disease. However, in Lancet, it's interesting to know that the virus shedding time may be lasted up to 24 hours. And then And you can see that even you use the reverse transcript inhibitor, it still takes about 22 days to resolve from the virus. And the median time for virus shedding is about 19 days in patients with severe disease status, and 24 days in patients with critical disease status. I think maybe you are familiar with that Taiwan has done something different, so it can survive the first attack from the Wuhan. Actually, we have several demographics which tell us that the disease prevalence is different among different parts of the country, the county. Currently, the disease prevalence is highest among New Taipei City and Taipei. And there are still some county which is far away from the virus in south, which is about the east part of Taiwan. And in Taiwan, the y-axis indicates the date of positive index patient. We have very, very few patients before March 9th. And then the disease, the population of disease, the disease population increased from the 11th of March. So you can see that the green color here means that the disease, the patient is local patient, and the red means that the disease is from abroad. And currently, most of the patient is about 20 to 29 years old, and very, very few people is above 70 years old. And most of the patients are female, and only about 45% are male in gender. The confirmed cases currently in Taiwan is about 385, and the local patient is about 54, and most of them are from abroad. Currently, we have only 6 mortality cases, and the 99 patients are cured by 3 tests which proved to be virus negative. Compared to the most of the countries, you can see that Taiwan has a mortality rate about 1.6, while South Korea, the disease mortality rate about 2%, and Japan is about 1.6%. And for China, maybe the mortality case is a little underestimated. It is reported to about 4.5, and in Singapore it's 0.3. Compared to most of the Asia country, the mortality rate for Germany is about 2.2. The mortality rate for Italy is 12.7. UK is 12%. So it's interesting because in Japan, I think the virus isolated, is not so far away from the rest of Europe, but maybe due to some policy difference, the patient who is above 70 years old in Italy, they will not be treated adequately. So maybe the disease itself is not so detrimental for human health, but due to limited medical resources, we are not able to treat all patients equally. To my understanding, I still think that the virus itself is not so virulent to human health, but maybe it's too easy to be contaminated because it can spread over cough or sneezing. Why Taiwan can survive the attack? I think there should be 3 key issues. The first is the professional leadership. We have a conference every day, so all our citizens can watch the television to see is there any new index patient, and also we will discuss about some policies which will be able to control the disease spreading. And the second is that we have some policy which based on the scientific rationale. And the thirdly, we have very tight cooperation between central and the local government. So that's why we can keep a low mortality rate. And the first of all, we begin to prepare for facial mask manufacturing at the beginning of January. So we have plenty of masks to protect from the virus inside. At the very beginning, we can only make 1 million masks every day. But due to the national policy, all of our factory begin to produce as many as much possible. So now we can make about 10 million masks every day to avoid the spread from cough or sneezing. Secondly, we have a very good statistics over index patient and also the cluster exposure. So you can see that from the newspaper, it's very easy to see where does the index get the disease from. Every patient has very clear interrelationship between the family, the index patient, and also where does the intervention come from mainland China or from Europe. It's all listed on the newspaper. So actually, I think every citizen in Taiwan is aware of the disease threat and also knows how to fight against the virus. All index patients are identified through PCR and quarantined according to national policy. At the very beginning, actually, the PCR detection is very low because we have only 1,800 capacities at the very beginning. But with the expansion capability, now we are able to perform tests about 5,000 every day. Maybe you may say that the number for detection is a little bit lower compared to the rest of the country. But don't forget that the index person in Taiwan currently is about 300 to 400. So we have very high percentage for tests per million people. I think according to our total population, that should be quite enough. So we can get our results from nasopharynx and oropharynx sample for test within 12 to 24 hours. And also, we collect the sample for sputum. And the plasma samples are also stored for antibody detection to see whether the patient can be classified into no virus, no antibody, or with virus but without antibody, or with antibody but no virus. This means that may be previously infected, or with virus and with antibody. This means that the patient may have inadequate responses to virus insult. We may try to use some plasma or some effective treatment drugs to cure the disease. All patients who was detected to be positive at the very beginning, they need to be quarantined for maybe up to 28 days until it proves to be 3 negative results for the PCR study. And we start border control very early at the beginning of February. So every passenger, when arrived at the airport, their details will be recorded, including their address, the telephone, and all the tourists will be monitored with mobile phone. If they leave the designated area, the police department will be informed. So we can know that who lost of the follow-up, and the policemen for the whole country will start to find where the patient is right now. And all aircraft crew wear the facial mask at the very beginning to avoid the transmission of virus from the crew to the tourist. And we have 3 levels of isolation. The first is self-health management. This means that the person exposed to salivation at the same time and destination, but maybe they are not exposed to the patient directly. And the second level is the home quarantine. This means that maybe he returned from abroad, but maybe he is not infected with the virus. And the third level, we call the home isolation. He exposed to intact patient directly, but may not have the virus immediately or may not have symptoms. So our government monitor the 3 kinds of persons every day to make sure that the disease is controlled very well. But however, we still think that as pulmonologists, we can still do something differently. We think that the innate immunity and also the humoral immunity is very important for disease control. So actually, we try to find some fundamental difference between the infected patient and also the patient who is not infected. We think that mucus, which is composed of immunoglobulin, defensin, and also some antimicrobial substance will be important. And also the macrophage, the NK cell and the dendritic cell are very important. So actually we started to do some immunoprofiling study, try to see who can survive the virus and clear the virus very quickly. Maybe they have very intact cell immunity. But if some patient who may be very old in age or maybe has some defect or the immunity, the immunophenotyping, which was performed by flow cytometry, can analyze the difference. And also, actually, we started to see if there are some microbiome association between the virus and also the airway mucosa. So our scientists in our university try to find if some microbiome associations between the virus clearance, the epithelial cell health, and also the cell movement, all together with the luminal immune cells. So I think that with these all efforts all together, we will be able to find some way to control the virus and to induce a sustainable antiviral immunity that helps to reduce the virus threat. And actually, we also think that maybe the weather and the humidity will be better to control the virus in Taiwan. Maybe you are familiar with the very old publication around the 1985. It's interesting because it's not so easy to do some study on coronavirus due to its biohazard. But from this well-designed study, we see that with coronavirus 229E, the virus survived better in low temperature and low humidity. But if we can increase the temperature up to 20 degrees, the virus cannot survive very well. And also, if we increase the environmental humidity, the survival of the virus is much decreased compared to humidity between 30 and 50. So this indicate that maybe in summer or maybe in early autumn, we may be able to control the virus spreading in open space. But however, we still need to be careful about the inevitable virus spreading in closed space. And I think you know that the virus can survive around the surface of different materials. For example, with steel surface, the virus can survive up to 2 days. With aluminum, the survival time is about 2 to 8 hours. What is more interesting that around the surface of PVC and silicone cover, it will survive longer. I think the study still have some limitations because this study did not compare the temperature and the humidity adequately. However, it still indicates that we still need to be careful about every surface which we may be touched every day to reduce the spreading between patient and also the health professionals. I would like to share 2 cases. Maybe we can discuss some medical details later. Actually, we have some very interesting cases. They have similar X-rays but different effects. For the first patient, this is a 28-year female. He returned from UK because he studied abroad. The BMI is about 38. The portable chest X-ray, which is performed around March 21st, you can see that there are some infiltrates around the left upper lobe. And from the CT, you can see that there are some common and uncommon changes for COVID-19. At the upper panel, you can see that there are some prebronchial infiltrates around left lingual lobe. And you can see there's some GGO changes about left lobe area. As you may expect that at the very beginning, we think that the female can survive the virus attack. But unfortunately, even she is so young, but maybe due to obesity in character, which limits the innate immunity. Because the innate ILC2 and ILC3 cell are involved in virus evolution. So we see that within 7 days, the X-ray progressed, the AADO2 and also the saturation of oxygen cannot be controlled very well. She started to breathe very difficultly at night. So we have no choice. We intubate the case. But interestingly, after the intubation with adequate lung expansion, and also actually we do not give her any virus targeting agent except hydroxychloroquine and also azithromycin. But the X-ray is actually improved. You can see the CT here. The GGO improved, but there's still some parenchyma changes around the right lower lung area. Currently, the virus is still there, but she extubated very smoothly, and the oxygenation status is much improved. So we're still looking forward to see whether there will be lung fibrosis or not after full observation period. At least now she no longer needs to be intubated. Now she has been transferred to ordinary ward. And let's see the second patient. This one is a tourist guide. He is a 60-year-old smoker. You can see the X-ray looks a little dirty compared to the normal chest X-ray. There are infills about the right lower lung and the left lower lung. But when we look into the computed tomography, even he has no symptom except a little dyspnea due to autodesiccation. You can see that there are some subpleural changes from left upper lobe, left lower lobe, right lower lobe, and also some part of the lung. So actually, at first we saw that he may not have virus detected because it looks like some chronic changes. We don't think that it is involved in the active process of the virus eradication. But unfortunately, he has positive study for a PCR study. So we think that he has coronavirus. But compared to the previous young lady, this man, although have some GGO changes, and even the X-ray become worse compared to previous X-ray, and also he has ileus. But interestingly, the X-ray even so bad compared to other patients. The chest CT improved gradually. So this means that the clinical course, if you compare the CT to the symptoms, maybe not so similar. So maybe we still need to looking forward to individual protection around virus. And we still think that every patient has its own clinical courses, which will be interfered by the treatment chosen by the physician. As the previous speaker mentioned, that we don't need to use steroids because it will impair the antiviral immunity. However, the symptoms still vary compared to those in America and those in Taiwan. At the very beginning, we have very, very few diarrhea cases. We also have no rhinorrhea. But with time, as more and more index come from Europe, we find that the symptom varied. So even remdesivir seems to be promising, and I think the recent publication in NEJM proved it. But we think that the problem is that the remdesivir still have some problem to discuss. The first of all is that should I give it as early as possible? What should be the optimal what should be the optimal dosage? What should be the optimal duration? So I think there's still some issues because in addition to the ACE2 channel, now we found that the TMP-SS2 channel may be another virus entry into the cell. So even we have so many findings regarding the promising medication, but I think that we still need to see what's the fundamental to have the virus infected into a patient or not. We think the nasal mucosa and the oral mucosa will be very important. As the pollution become a more and more emerging problem for most countries, actually, we are facing a threat from the air pollution in addition to the virus. If the patient has renal sinusitis, they tend to breathe from their mouth. So allergen, air pollution, and the virus will impair the innate immunity and also the cellular immunity over the bronchial mucosa. And now evidence indicates the allergen will impair the epithelial integrity. So under this circumstance, we will think that we should be care about the air pollution related airway changes. And that's why I think that the Pintex can put some efforts to use the bronchoscopy based on the optical enhancement to see if there mucosa changes for those who infected with virus. The those without changes and can survive the virus attack very well. Because in the future, I think most of the population in the world may have positive for serum study. But it's still unknown that why sometimes the virus are limited to upper airway, but some not. So maybe the bronchoscopy will be a good clue to find the true evidence. I think we will have emerging straight from respiratory virus every year or maybe every season. Now we have problem over the north in Taiwan and also the country. But I think that maybe 3 months or later may come from Australia because the weather changes. We are from spring to summer, but they are from summer to autumn. So the weather, which is good for virus threat, I think we should be aware that we still need to know more about the airway epithelial protection, how to keep a balance between the mucus production and the accessory movement. And also, we need to have a tight cooperation between physicians, scientists, and the epidemiology specialists to find the virus as early as possible and try to find how to isolate the infected patient to avoid the contact from the rest of the population. And also, we think with global efforts, we may conquer the disease. Thank you. Yeah.
Thank you, Dr. Pai.
Yeah.
May I request Dr. Tinku to please introduce yourself first and continue with the presentation?
Okay. First of all, very good evening, one and all. At the outset, let me thank Pentax for giving me an opportunity to speak a few words in this webinar on COVID-19. Well, I'll be in the next few minutes. I'll be talking on the few aspects regarding the role of bronchoscopic procedures during the pandemic of COVID-19. Well, to disclose, as of there is no conflict of interest. I have not accepted any form of financial grants from Pentax Medicals, and there is no throughout my presentation there is no intention to project any particular bronchoscopic manufacturing company as well. These are my references. So the entire set of slides was prepared from the following guidelines. The first and foremost from the AABIP, the position statement on bronchoscopic procedures during COVID-19 infection. Then from the University of Nebraska guideline for usage of bronchoscopy during COVID-19. As well as I have referred to this particular article, that is the bronchoscopy in the age of COVID-19, which was recently published in JOB. And a few points were taken from the International Pulmonologist Consensus on COVID-19, and also due courtesy to Google for whatever images which I have taken for preparation of this presentation. So let me start off my presentation with this particular slide, and this is a study which was recently published in JAMA and which created a lot of interest. And this particular table which I put up has created a lot of interest among especially among pulmonologists regarding the role of bronchoscopy in COVID-19, because as per this study, the performing a bronchoalveolar lavage has shown to yield around 93% results when you're collecting a respiratory respiratory sample for testing your RT-PCR. The BAL sample has shown to give us around 93% positivity, as well as the bronchoscopic brush biopsy around 46%, sputum 72%, nasopharyngeal swab at 63%, and oropharyngeal swab at 32%. So this particular table has drawn in a lot of interest among pulmonologists regarding the performance of BAL in COVID-19 patients. But be cautious, because As per the various guidelines, bronchoscopy is not a diagnostic tool for COVID-19, even though the positivity is touching close to 95%. But for the reason is that bronchoscopy as well as induced sputum, both of these procedures are aerosol generating ones, and there is always a potential for transmitting infection when you're performing a BAL or as well as a bronchoscopic brush biopsy or an induced sputum. So the primary or the preferred method of choice when you're suspecting a patient to be suffering from COVID-19, and if you want to obtain a respiratory specimen sample in order to diagnose, and if you want to send it for RT-PCR, the preferred method of choice is to obtain a nasopharyngeal or an oropharyngeal swab. Or else, if the patient can expectorate sputum, you can send the sputum. And any procedures like any bronchoscopic procedures as well as induced sputum is not recommended for collecting, for assessing RT-PCR. So before giving a green signal for bronchoscopy, you should always evaluate your patients and assess the risk if possible. And there is no need to jump in and do a bronchoscopic procedure, especially when a pandemic is going on. You should be wise enough in choosing your patients when you're opting for bronchoscopy. And if your patient belongs to a category of a non-urgent bronchoscopic procedure, it would be wise to always delay the procedure for a period of 4 to 8 weeks. And when you're delaying the procedure, do assess the risk factors as well. And if your patient is COVID positive, try to avoid performing bronchoscopy in this set of patients. So the AABIP as well as the Nebraska University of Medicine has classified the bronchoscopic procedures into 3 different types, like the certain conditions which falls under emergency category and certain ones under the non-urgent as well as the urgent category. Now let's see what are the conditions which has to undergo a bronchoscopic procedure on an emergency basis. First and foremost, any symptomatic central airway obstruction, like if the patient is presenting to your ER with stridor, and on evaluation, if you are found to have the patient is having there is a central airway obstructing tumor, or if there is significant mucus plugging on a ventilated patient, or if there is an impacted foreign body in the central airway compromising the respiratory function, such patients should be taken up for bronchoscopy on an emergency basis. In case of massive hemoptysis, if you're finding it difficult to manage with your IV or oral hemostatics, and if the patient is having an ongoing bleed in spite of taking the patient for a bronchial artery embolization, you can take this patient. You are justified enough to take this set of patients for an emergency bronchoscopy. As well as if your patient is suffering from a significant amount of central airway stenosis, like a tracheal or a bronchial stenosis, such set of patients also can be taken for an emergency bronchoscopy. And if you have stented the patient for a central airway obstruction, and if you suspect that the patient presented with symptoms suggestive of a migrated stent, such patients also can be considered for an emergency bronchoscopy. Now let's see which all patients belongs to the category of urgent bronchoscopy. Suppose a patient presents your ER or a clinic with a suspicious lung mass on a chest X-ray, and whether the question is whether should you do the bronchoscopic biopsy or should you delay the procedure. So if the patient, you have to outweigh the risk versus benefit ratio. And as per the guidelines, if the patient is having a suspicious lung mass, preferably you can get an RT-PCR from the patient. You can send a throat swab for RT-PCR and wait for a period of 1 week. And if the RT-PCR is negative, you can take that patient for a bronchoscopic procedure or an EBUS guided TBNA for obtaining a diagnosis. If there is a foreign body aspiration without any significant involvement of the airway, if the airway is stable, you can preferably wait to send an RT-PCR and make sure that the patient is negative And in case of mild to moderate hemoptysis, as well as if your patient needs a whole lung lavage, such patients, as well as if your patient is a candidate of pulmonary pulmonary infection post lung transplant or bone marrow transplant or any other form of transplant with a suspected pulmonary infection, all these groups of patients, all this subset of patients belongs to the urgent bronchoscopic category. Now let's see which all patients do not require urgent bronchoscopy. If the patient is suffering from a mild or a mild tracheal or a bronchial stenosis, and for clearance of some amount of mucus plugs, and if you suspect a sarcoid in a patient, as well as any form of interstitial lung disease, which requires a cryobiopsy for diagnosis, all these groups of patients can ideally wait for more than a month at least in order to undergo bronchoscopy. So the AABIP guidelines have recommended to delay the procedure until May at least. The non-urgent bronchoscopic patients can wait until May. There is no urgency to jump in and do bronchoscopies for this subset of patients. As well as if you want to evaluate for tracheobronchomalacia and performance of performing bronchial thermoplasty, all these procedures can be delayed. Now let's see if your patient, if you're suspecting if there is a confirmed case of COVID-19, whether should we perform bronchoscopy or not. So as I already mentioned to you, preferably you should avoid performing bronchoscopy in this subset of patients. And because there is a significant chance for aerosolization, and this is an aerosol generating procedure, so preferably avoid performing bronchoscopy, any form of bronchoscopic procedures in COVID positive patients. And let's see what are the indications for performing bronchoscopy in COVID positive patients. So suppose if your patient is on a ventilatory support, and the patient is not able to maintain adequate tidal volume, and if you're suspecting there is a mucus plug impaction, and in such instances, obviously you can do a bronchoscopic procedure with necessary precautions to remove or clear the mucus plugs. As well as in order to rule if your patient is not improving with a standard line of management for COVID-19, and if you're suspecting if you're thinking in terms of an alternative diagnosis, or if you think that if the patient is having a coexisting different pathology, you can perform a bronchoscopy in such instances also if you want to obtain a biopsy. And bronchoscopy can also be performed in COVID-19 positive patients if they are suffering from massive hemoptysis also. In order to perform any endobronchial blocking procedures, a bronchoscopic procedure can be performed in COVID-19 positive patients. Now let's see what are the precautions which has to be taken care of when you are planning to perform a bronchoscopic procedure in suspected or confirmed COVID-19 cases. So as I mentioned before, preferably try to avoid any bronchoscopic procedures. And if you happen to do the bronchoscopic procedure, make sure that such procedures is being performed in a negative pressure room isolation. And try to limit the number of people who are there in the bronchoscopic suite or the negative pressure isolation room because due to the shortage of PPE. And all personnels who are the bronchoscopist as well as the anesthetist and the bronchoscopic technicians who are there in the room should wear the standard PPE kit. So this is how a standard PPE kit looks like, and it can be, this is the PAPR kit, that is a powered air purifying respirator, which nearly gives us 100% protection from aerosols. And this is a costly affair, and this is a blower, and which is attached to a hood. And the advantage of using this particular device compared to an N95 or an N100 mask is that you can avoid the suffocation associated with using N95 mask, especially if you're doing a prolonged procedure. So a prolonged procedure, any prolonged bronchoscopic procedure, if your institution can afford, and this would be the ideal PPE kit of choice. As well as make sure that if there is a facility for, if a disposable bronchoscope is available, try to use it as much as possible. And if you're obtaining a BALS specimen, make sure that limit the amount of sample. 2 to 3 ml of specimen is more than adequate in order to perform RT-PCR, and make sure that the container in which the bowel sample is been taken should be sealed adequately, and it should be sent to the microbiology lab. And after performing bronchoscopy, make sure that the disinfection protocol should be followed on a mandatory basis. That is, the bronchoscope and its accessories should be disinfected according to the standard infection control program of COVID-19. And when you always make sure that preferably almost most of your patients who are suffering from COVID-19 should be intubated, and they should be sedated and paralyzed. And this is not the time to do any bronchoscopic procedure under conscious sedation, because your patients are bound to cough, and it has got a huge potential for transmitting infection to the bronchoscopist as well as to the bronchoscopy technicians. So preferably, most of your bronchoscopies, at least till this pandemic ends, has to be performed under sedation, and the patient has to be paralyzed if possible. So preferably do your bronchoscopies, as well as let it be flexible bronchoscopies or rigid bronchoscopies. All this set of scopies should be performed under general anesthesia to minimize the risk of aerosolization, as well as make sure that you limit the number of medical personnel in the negative pressure isolation room. And also make sure that after performing this procedure, there has been a lot of ongoing data regarding the donning and doffing procedures, how to perform donning and doffing, and make sure that the PPE kit has been disposed in a proper way to avoid the spread of infection. And there is also an ongoing discussion regarding the utility of the safety box when you're performing any bronchoscopic procedure or intubation, tracheostomy, or any form of aerosol generating procedure. And this is a useful tool which has been widely used across the world ever since the COVID-19 pandemic has started. And studies have proven that without when you do a bronchoscopic procedure or intubation without any form of protection like this, you are bound to the aerosols is bound to get spilled onto the bronchoscopist or as well as the anesthetist when you're performing this procedure. So this is a relatively cheaper tool, and which can be easily made in each and every country, and which has been made up of acrylic. And it is a relatively cheaper device, and it is a valuable tool when you're performing bronchoscopic procedures as well as intubation to reduce the risk of spillage of secretions. So what else? What are the other precautions which you have to obtain when you're performing bronchoscopy in a non-urgent condition? So as I mentioned before, any non-urgent condition, we preferably delay the procedure until May 2020 or till the pandemic wave subsides. And again, if you're planning to do a bronchoscopy in such group of patients that in which there is no evidence of suspicion, or there is no evidence, or if you're not suspecting COVID-19 infection, you should make sure that you ask all these points. The bronchoscopist should ask the patient for a recent history of travel to endemic areas. Most of us know which are the endemic areas, so the travel history has to be asked to the patient. And also, if the patient is presenting with a history of fever, cough, make sure that you delay the procedure. Send an RT-PCR, wait for the results before jumping and doing a bronchoscopy. And if there is an evidence of community spread in your country, please make sure that all non-urgent bronchoscopic procedures has to be delayed on a mandatory basis. Due to the reason is that most of us are facing a shortage of PPE kits, as well as I'm not sure whether all the hospitals has got a facility of performing bronchoscopy in a negative pressure isolation room. So due to this reason, all non-urgent bronchoscopic procedures has to be delayed on a mandatory basis. Now moving on to the rigid bronchoscopic procedure. So among all the bronchoscopic procedures, compared to the flexible bronchoscopy, the rigid bronchoscopic procedures are time consuming and it has an open circuit. So compared to the flexible bronchoscopic procedures, when you're performing a rigid bronchoscopic procedure, there is always a chance for significant amount of transmission of the aerosols due to the presence of open circuit. So if the rigid bronchoscopic procedure is not an emergency one, try to delay it as much as possible. But you can perform a rigid bronchoscopic debulking of the tumors if your patient has been presenting with significant significant central airway obstruction, like if the patient is having presence of stridor and respiratory failure. That is an indication for performing an urgent rigid bronchoscopic procedure. So when you're doing a rigid bronchoscopy, always try to make sure that it has been done with all essential precautionary measures has to be taken. Try to, if the PAPR kit is available, make sure that it has been used when you're performing a rigid bronchoscopic procedure. So to conclude my talk, bronchoscopy is not considered as a diagnostic modality for COVID-19. I've already discussed in detail regarding what exactly is the role of a bronchoscopy in COVID-19 positive patients. The role is, if your patient is intubated, you can clear the mucus flux. If your patient is suffering from a massive hemoptysis, you can manage it with the help of a fiber optic bronchoscope, and also to rule out alternative diagnosis. So this is the only indication for performing bronchoscopy in a COVID positive patient. And preferably, when you're performing the bronchoscopy, it should be on ventilated patients, and the patient should be well sedated and paralyzed. And if there is a facility option for a disposable bronchoscope, and make sure that it has been used for your bronchoscopic procedures. And minimize the number of people who are assisting the procedure, and preferably do these procedures in a negative pressure isolation room, and make sure that all the people who are standing inside the negative pressure isolation room has to wear a proper personal protective equipment. And standard disinfection protocols should be followed in each and every institution which is performing bronchoscopic procedure, and make sure that it's not only cleansing or cleaning your fiber optic bronchoscope, which is important. You have to clean the entire and disinfect the entire bronchoscopic system, which includes the video monitors as well. And among all bronchoscopic procedures, rigid bronchoscopy has got the maximum risk, and if possible, avoid it. And rigid bronchoscopic procedures in the present pandemic era of COVID-19, it is indicated only for management of central airway obstruction, and it should be performed by the most skilled person in your team, because this is not the time to teach your trainees regarding how to intubate the patient with the rigid bronchoscope. We don't have that much time to play around with the bronchoscope. For the reason is that it increases the time, it increases the chances of aerosolization. So preferably, the most skilled person in the team has to perform this procedure, especially the rigid bronchoscopic procedure. And as everybody knows, most of the interventional pulmonologists are pumped up with adrenaline. And unfortunately, this is not the time to have an adrenaline rush regarding for doing the procedures. And make sure that you should be wise enough in choosing any form of bronchoscopic procedure, due to the reason is that the prevention is always better than treatment. Thank you.
Thank you, Dr. Tinku. May I request Dr. Anantham to please introduce himself to the attendees and then continue with the presentation, please.
Hello, everyone. Thank you for the kind invitation, and thank you for inviting me to share my observations on some of the published data around this. I'm from the Sing Health Lung Center, and I'm also the Director of Medical Humanities, and I work at the Singapore Medical Association Center of Medical Ethics and Professionalism. So, obviously, ethics is a big issue in a pandemic. In a crisis like this, we have seen the best of people. We have heard many heartwarming stories, many stories of bravery and so on. But crisis also brings out the worst in people, right? Because it plays on our insecurities and our fears. And for this reason, there is there is a great need for clear guidance on the right thing to do and what not to do. The other issue with the pandemic is that because of a surge in cases, there is no time to reflect, there's no time to get second opinions and to have discussions and consults. So again, there is a great rush to make reflexive decisions, which may be regretted. And for this reason, some form of guidance is appreciated. Now, the ethical issues in a pandemic are broad, as I've listed out here, and these are only some of the issues. They range from triaging of ICU resources, allocation of personal protective equipment, what are the obligations of healthcare workers and what risk should they take. For the public, the restriction of liberties with lockdowns, contact tracing and privacy issues, especially if you're going to use handphones, the fast tracking of research, and how do we allocate new therapies. Now, I won't be able to cover all of this, and I only intend to focus on the ICU triaging area as sort of a paradigm that you can use to maybe think about the rest of the issues. So perhaps I'll start with this paper that we put out more than a decade ago, before the H1N1 pandemic, about the obligations that physicians had during an event like this. And we actually mapped out all the issues that are involved. This includes everything from personal protective equipment to the necessary training in infection control, the psychological problems and dealing with burnout, to logistical issues like if we are having a lockdown, how do we transport healthcare workers to hospitals? Where do we lodge them? How do healthcare workers manage elder care and child care? And then, of course, objective triage criteria and independent triage teams. Because if you don't have these triage criteria, you add on to the stress and the burden that the frontline healthcare workers are having. So before I go into that, maybe I'll share a little bit about what is the Singapore experience with COVID. As you can see, we had initially a very good response to the first wave of COVID that came to Singapore from travelers from China. This was a combination of aggressive testing, contact tracing, and quarantine measures. And we actually managed to get the numbers of new cases actually down to 0 by the end of February. However, as the pandemic exploded across Europe and North America, more travelers brought hundreds of cases back to Singapore. And now, as you can see, we are in almost an exponential phase of the pandemic, which is why we are talking about triage criteria and so on. In Sing Health, which is where our lung center is, we have already managed somewhere close to 450 cases of COVID-19. So before I talk about ethics, we should talk about data, because good ethics depends on good data, not just on principles. So what is the data around patients who are going to go to ICU due to COVID? Now, the first study that I'm going to bring out is the one from Northern Italy, right? And Northern Italy faced its first case of COVID on the 20th of February, and by the 18th of March, they had 17,713 cases. And this data was pulled from 72 hospitals which had linked ICUs. And these are all RT-PCR confirmed cases. And you can see that the median age of the patients who went to the ICU out of this 1,591 patients was 63. Right? I know that there were much publicized exclusion criteria that came out of Italy. And I don't know how much of those exclusion criteria were applied. But if you can see the histogram, you can see that a number of elderly patients, even into the 80s and 90s, were taken into the ICU. The other thing that you will notice about the patients in Italy, 82% of the ICU patients were male. So the patients who went to ICU, the vast majority of them went in for respiratory support. And again, 88% of them needed invasive mechanical ventilation. Reason for this may be that at that time, because of resource constraints, NIV was performed outside the ICU. It's also worth noting, if you look at the PF ratio, the median PF ratio was 160 in these patients. So of all the patients who went to ICU, if this were ARDS, this would be considered at least a moderate ARDS. And you can see over a quarter of the patients were treated with prone positioning, and ECMO was not used very frequently. Now, if you look at the characteristics of these patients, as I said, the PF ratios were low. Actually, a number of them were, the PF ratio was under 100, which would put them in the severe ARDS group. 89% of the patients had FiO2 that exceeded 50%. And if you look at the PEEP requirements of these patients, the median PEEP was 14, and many of them required PEEP beyond that as well. And if you look at the outcomes of the patients who went to ICU, you can see that at the time of publication of this study, nearly 60% of the patients were still in the ICU, and of those who were no longer in the ICU, 61% of those patients had passed away. So the mortality at that time was 61%, not counting all those patients who were still in the ICU. And if you look at the median length of stay, regardless of whether the patient was just discharged or still in the ICU, we are looking at a median length of stay somewhere in the region of 8 to 10 days. So again, these patients who go to the ICU are not short stayers. They stay in the ICU for some time. Now, moving on to the experience from China. Now, this is not a multi-center study. This is a single-center study. As you can see, the median age of these patients was a little bit lower than in Italy. 40% of these patients had chronic illness. And again, the majority of these patients came into the ICU for respiratory distress. The data from this group also shows a number of other organs that needed support, cardiac support, kidney support, and then there were a number of patients had liver dysfunction. And again, the majority of these patients needed mechanical ventilation, and a number of them needed prone positioning. And as you can see, the other organ supports, including renal replacement therapy and vasopressors. So what was the outcomes from these patients? Well, first of all, you can see the SOFA scores of these patients, the sequential organ failure assessment scores on day 1 was not actually very high, either in survivors or non-survivors. And yet the mortality in this group was again in the region of 61%. The median length of stay was 7 days for the non-survivors. I didn't mention that in the Italian group, the age was found to be prognostic factor in terms of identifying patients who had higher risk of mortality. Age of greater than 64 was associated with higher mortality as opposed to those who were under 64. In this study, in multivariate regression, there was a stepwise increase in mortality for every year of age. Similarly, there was higher mortality if there was higher SOFA scores on day 1 and higher D-dimer scores on day 1. So if you look at, and then as already mentioned, there was viral shedding that was noted many days, after the onset of illness, 20 days up to 37 days. And this has, again, implications in terms of how you triage patients, because how you're going to step them down from the ICU. If you tracheostomize them, can you send them to a weaning unit, and so on, will be determined by whether you can manage the necessary infection control for patients who continue to shed the virus. Right, so a few observations, and again, this is not an ICU talk, and I'm not here to tell you how to manage these patients, but a few observations are that the patients go to ICU for respiratory distress. There's a high incidence of mechanical ventilation, especially invasive mechanical ventilation. The PEEP requirements of these patients tend to be at least in the moderate range. A number of these patients needed prone positioning, and so related to the high PEEP and the prone positioning, the sedation and analgesia requirements were high. These patients needed to be on mechanical ventilation for some days. And again, in our experience as well, if you try to extubate them too early, the reintubation risk is relatively high. And now, many of these patients have a hyperinflammatory cascade that progresses over the days after the patients get into the ICU, and some of them need multi-organ support, and the expected median length of stay is at least in the region of 8 to 10 days. And finally, there's continued viral shedding. So any triage criteria that we come up with needs to pay attention to the particulars of this illness and how it's managed in the ICU. Now, when we think about ethical principles, clinicians typically think of the 4 principles of biomedical ethics, but it's difficult to use these principles in a pandemic. It's very hard to think about how to honor autonomy, especially when you're thinking about population health. Similarly, the challenge with the 4 principles is that what do you do when the principles come in conflict? And in a time where you don't have the luxury to reflect and discuss, it can be challenging. So what happens if beneficence comes into conflict with justice, or non-maleficence comes into conflict with autonomy? How do you resolve these issues? So UNESCO has actually put out a statement on some of the ethics positions. This includes that policies which are not based on sound scientific knowledge and practices are unethical, as they work against the effort to build up a common response to a pandemic. So again, we know people are desperate and they're desperately ill, but if we go on giving untested therapies in a non-research setting, we undermine the generation of knowledge which all of us can use. Our right to health can be guaranteed only by our duty to health. And again, this is obviously very pertinent with all the lockdowns going on. And so when people are told to stay at home, they need to, in spirit, stay at home, and do their part. And then macro and micro allocation of resources is justified on the basis of justice, beneficence, and equity. And on this point, I'd just like to highlight that equity is not equality, right? This is not treating everybody as the same, right? As you can see from this cartoon, equity is about addressing the needs of the most vulnerable in society, and the most vulnerable in society need a special consideration and adequate resources to help them. And this is because vulnerable individuals become even more vulnerable in a pandemic. And if you watch the news reporting, you know that the poor in America are disproportionately affected by this pandemic. The urgency of finding a cure should not preclude responsible research practices. And human rights should always be respected, right? Autonomy and privacy should be carefully balanced against safety and security. And this is where the principle of proportionality becomes really, really important. So the first part of triaging of ICU resources is try to avoid it, right? You try to reduce scarcity, right? We have been involved in COVID now for more than 2 months, and we have been trying, right? You try and you prepare by anticipating challenges, stockpiling medications and consumables. You conserve your PPE because there is a worldwide shortage of this stuff. Where possible, we substitute or adapt resources. For example, using transport ventilators as to ventilate patients in the ICU, and then reuse and reallocate. I mean, if there are other facilities, other ICU hospitals with ICU beds, we transfer them such that no one health institution is compromised. So as I said, we've been in this for some time. We've already published some of the work in this on how to prepare ICUs. And again, this is not just about infrastructure and ventilators. It's about training staff to be able to manage critically ill patients. The Lung Center has also put up a whole series of refresher videos on its webpage so that those who have not done or who are a little rusty with their ICU can refresh, as well as how to use a transport ventilators to ventilate patients who are in respiratory failure. So if you've done your best and you've optimized your resources and there's still scarcity, then what do you do? Right? This paper came out in the New England Journal, which talked about the following substantive values. Right? Substantive values are essentially strongly held ethical ideals, right? Which tell us what is the right or wrong thing to do in face of uncertainty and conflict. And the four values that were put up in this paper was to maximize benefits, to treat people equally, to promote instrumental value, and to give priority to the worst off. So again, attending to the most vulnerable in society. So if you look at these values and how to actually apply them, for maximizing benefits, you can either save the most lives, which is actually short-term survival assessment, or save the most life years, which is it's a longer-term life expectancy. And clearly saving the most life years is biased in favor of younger people, because you will obviously be able to save more life years by saving them. Then how to treat people equally. And as you can see that they have rejected first come, first served methods of doing this. Largely because if you use first come, first serve, it unfairly favors people who have easier access to acute care. And it also excludes patients who just happen to fall sick later, which obviously undermines equity. So if you had a tiebreaker, random selection is preferred. Promoting instrumental value, either retrospectively or prospectively. And again, this is why I say you need to look at the data before you apply the principles. So if you wanted to use prospective instrumental value to give priority to healthcare workers, you have to understand that based on the data, the probability of a healthcare worker falling sick developing respiratory failure, being intubated and sent to the ICU, and then recovering and coming back to contribute to the pandemic effort is actually very remote, right? So it is very hard to justify giving priority to healthcare workers purely on prospective instrumental value. And then, of course, attending to the most vulnerable, sickest, and the youngest, and so on. Now, different flowcharts have developed in order to actually do the triaging, and they look like this. Typically, it has got 3 different sections. Okay, there's an inclusion and exclusion criteria for patients who should come into the ICU, and this inclusion-exclusion criteria should also include respect for autonomy. So patients who have made an advanced care plan should have those care plans honored, and if they didn't want to come to the ICU, they obviously shouldn't be brought in. So you should have explicit inclusion and exclusion criteria who is going to come into the ICU. And for patients who meet those 2 criteria, the next phase is a prioritization phase. And this is where the triage teams come in. I'll cover this in a later slide. And then there's a reassessment phase. And again, this is where I said we need to look at the data of the current pandemic. If you follow this chest paper and reassess the patients at 72 hours, you are probably going to do it too soon. Because as I said, these patients are going to be in the ICU for 8 to 10 days at least. If at 72 hours they haven't improved and you're thinking of withdrawing care, you'll end up cycling resources very quickly and withdrawing care on patients without giving them an appropriate chance to recover. And in the end, you might end up having a higher mortality by doing this kind of frequent cycling. So what kind of framework should we use? Ventilator use should be presented as a time-limited therapeutic trial, not as an unlimited promise to appropriately set expectations. And this is actually data-driven because, as you can see, even the patients who came to the ICU and who were appropriately treated, the ICU mortality, at least from the China and Northern Italy data, was in excess of 60%. So there is no even if you do get an ventilator and if you do come to the ICU, the chances of survival is less than 50%. As I said before, the duration of trial of ventilation cannot be too brief. You don't want to rapidly cycle these patients and withdraw patients who might have survived. And finally, the idea of having a triage team, an officer, to make the decisions in order to take the stress off the primary team so that they can focus on managing the patient and advocating for the patient. Excuse me. And then as far as prioritization of patients is concerned, there are multi-principal, multi-dimensional scoring systems which are available, which are obviously better than single-dimensional scoring systems. So you can use the SOFA score as a short-term prognostic identifier, and then major comorbidities as a long-term survival prognosticator. And again, I just want to highlight that if you use this table, at least based on the China data, most of these patients had very low SOFA scores. And to use these kind of systems may not work in COVID, and we need to reevaluate it as we move along, because it may not be discriminatory if all the patients end up having SOFA scores of less than 6. This paper also clearly highlighted what they meant by major comorbidity so that there is no ambiguity. And if your triage team is to work well, you need to have good procedural values, right? Procedural values are important in situations where you expect people to have to disagree about the substantive values, and you don't have the time to have long discussions. So you need to be able to have clear and consistent criteria for the triage teams to work, And you also need to put in legal protections for the triage teams such that if they follow the explicit criteria, then they will escape prosecution. So my concluding observations, COVID-19 related respiratory failure has a guarded prognosis. Okay, I know that the mortality rate varies from country to country, but at least in the biggest studies of ICU patients that have been put up so far, the mortality rate of those patients appears to be in excess of 50%. There is a lot of talk in the news about ventilators, but ICU care clearly involves so much more. It involves the consumables, it involves the manpower, it involves the training, and just having ventilators alone is not going to save patients. I would urge us to use data to inform decisions. The principles that we use can be gleaned from international data. The criteria that individual triage teams actually use on a day-to-day basis can be informed by having local dashboards so that the triage team knows what is the surge, what is the ICU capacity that's left, how stringent the criteria have to be on a certain day. And finally, the bedside prognostication can be used by using validated prognostication tools so that the prognostication will be unbiased. You need to communicate all decisions truthfully, both to the patients as well as to their families and to the public, and be explicit about what we're doing. And something that I didn't really touch too much about because I was talking mostly about the decision making, is that we mustn't forget our duty of care. So even the patients who are deemed to be poor candidates for ICU care, they need to be cared for. They need to have access to necessary palliative care, and we must ensure that their suffering is minimized as far as possible. And with that, I will end my talk. Thank you.
Thank you, Dr. Anantham. So now the webinar is completely open for questions. We already have a couple of questions with us. So the first question is from Dr. Imran Khan. The question is, when to suspect COVID-19 in allergic rhinitis? Patient, if he has cough in the last 1 week and no other symptoms.
Who would you want the question to be answered by?
Ma'am, anyone can.
Okay, I think the symptoms related to the COVID-19 is varied from country to country, because if a patient suffers from allergic rhinitis, we tend to see whether it's allergic type or air pollution type. Most of the patients in Taiwan, they tend to have seasonal allergic rhinitis, but some patients may also have postnasal dripping. So because some patients travel abroad from other country, they are not accustomed to the weather in Taiwan. So I tend to use the antihistamine together with some pseudoephedrine to reduce the vasomotor rhinitis, also to prevent the histamine releasing from mast cell. And most of the patients who respond very well to antihistamine, they tend to be negative for the PCR test. But with some rare cases, they may still have rhinorrhea and so nasal stuffness, and so also some may lose their smell and odor test. So under that case, we will do PCR study directly. But luckily, currently, most of the patients in Taiwan even have allergic symptoms. They are test negative. But in other countries, I think those who fail to respond to antihistamine should receive the PCR test if they have no symptoms before. But most of the time, we tend to check the trace rate altogether, because if you have allergic rhinitis for a long time, the virus may shed into the lower airway. So together with X-ray and also the nasal symptoms may be positive indication for PCR test.
Thank you, sir. The next question is from Dr. Harshini. She is asking if the PPE is reusable. In what conditions can we reuse the PPE?
Can I answer that?
Sure, ma'am. Please go.
So usually, Harshini, PPEs are one-time use only, but there are certain components of the PPEs which can be reused, especially like the goggles and sometimes the face shields that you use. They need to have certain kinds of, they have to be put through certain methods to be reused. But usually the PPE clothes that you wear are usually one-time use only. Okay, only some components can be reused, but by very vigorous methods of sterilization, such as the goggles and the shields that are used.
Thank you, ma'am. The next question is from Dr. Sunil Jadhav, and he's asking, what are the symptoms of coronavirus?
I guess that question has been already been answered in detail by Dr. Sushmita.
Yes. Okay.
Sorry,
the next question is from Dr. Imran Khan, and he is asking, can we do antibody test in asymptomatic career patients?
The question will be, why would you want to do it? And then what's the purpose behind this? I mean, for diagnosis of an acute infection, it obviously serves no purpose. Subsequently, when we, as we come out of lockdowns and we want to restart things, some people have mentioned a possibility of doing antibody testing and identifying a cohort of immune people who may be allowed back out of lockdown first to restart, societies which have been, severely paralyzed by this pandemic.
One more point I would like to add on this question. I feel this is not the right time to utilize the facility of antibodies, the various antibody tests for testing asymptomatic population. As you all know that every country is facing a severe shortage of various diagnostic kits, and as per the recommendation, all these antibody tests can be used for assessing the community spread of the disease on a wide scale basis. And preferably, asymptomatic patients should not utilize the facility of any form of diagnostic modality right now, because we are in short of most of these diagnostic kits.
Just to add to that, in some of the countries where healthcare workers are lesser and are going into quarantine, sometimes they use the antibody testing to see if they are immune enough and can come back to work. And that's where the only...
The gold standard test is not an antibody test, and it is the RT-PCR. And compared to RT-PCR, the sensitivity of antibody test is way too less. And most of the antibody tests are using serum for assessment of antibodies. And as you all are aware that it takes time for the antibodies to build up, and usually it takes from 7 days of infection and to develop the IgM antibodies, and IgG starts to peak from day 14 of infection. So it's not a gold standard investigation of choice. And if you want to confirm the presence of COVID-19, RT-PCR is the standard modality of investigation. And a quick answer to your question is that if you're not having any form of symptoms, preferably not get any form of investigation done.
Okay. Thank you. The next question is from Dr. Sashi Bhusha. And he's asking if the swab test is positive after the 15th day, what to do next?
Your question is that after treatment, if the swab is positive, or?
The question is written, if the 15th day, the sample of swab test is positive, what to do next?
I feel he might have, his question would be after treatment, if the swab is still persistently positive. I feel that is his question.
Okay.
Is it?
So let's answer in that way only.
Okay. If the swab is persistently positive, then the patient has to be. There have been certain cases even coming from India regarding the persistence of swab positivity, especially a celebrity was there. The swab was persistently positive. Even in spite of 2 weeks of treatment, the swab was persistently positive. The first, second, and third swab which was taken was positive. And she was kept in, such group of patients, if they're not having significant symptoms, and after treatment, if the swab is positive, they have to be kept still under isolation, under close monitoring until the swab is negative. So in order to discharge a patient who's been treated for COVID-19, the criteria is that at least 2 swabs should be negative in order to discharge a patient. 2 swabs, RT-PCR has to be negative, 24 hours apart.
Okay. Or I would add that you should keep the patient quarantined or isolated at home, for example, because the patient is still potentially infectious.
Sure, sir. The next question is from Dr. Ratan Singh, and he's asking to please elaborate the role of hydroxychloroquine and azithromycin medication in the treatment of COVID-19 and the associated complications and side effects.
As you all know, hydroxychloroquine, there is a lot of debate regarding whether it is a useful treatment molecule or whether it can be used on a prophylaxis basis. So as mentioned by a couple of our speakers during the initial presentation, HCQ predominantly acts on the ACE2 receptors. That is, to talk on a simpler way, the COVID-19 virus, if it actually binds to the human cells, in order to bind to the human cells, it needs to, the target is the ACE2 receptors. So HCQs blocks that particular pathway, and thereby that is the way it works. So both HCQ as well as azithromycin works in a similar way, and thereby it reduces the chances of viral replication. And if you ask me whether it is a good prophylactic molecule, so far the trials have not proven that it is a useful molecule which can be used for prophylaxis. But if you ask me about whether it is a useful treatment modality or not, it is definitely the recent trials which have shown that it has got a good amount of potential for treating COVID-19 patients. And most of the centers have started adding azithromycin also along with it. And regarding precautions, preferably try to avoid this molecules in patients with a known history of arrhythmias or any other form of cardiac comorbidities. And especially in elderly population, use it with caution. And because it has got the potential to prolong the QTC.
Okay, sir. The next question is from Dr. Sapan Kumar. And his question is, can you please outline the current accepted treatment algorithm in brief?
Okay, is it about India or across the world?
So it's across the world, sir.
Okay. So regarding India, we have a set of, I guess most of the guidelines have got have divided the patients into 3 different categories, like patients who are suffering from mild illness, then to moderate to severe illness, and those patients who are suffering from the critical care, who are bound to suffer from critical care illness. So the patients who are suffering from mild illness are the group of patients who are suffering from rhinitis, minimal amount of cough and sore throat, and such group of patients can be managed at home, or they can be advised to home quarantine, and no specific treatment actually is required for this set of patients. And when they are under home quarantine, make sure that your healthcare professional, let it be a doctor or any person associated with the government, has to be in touch with these patients. At least every 48 hours, they should give a call to those set of patients and assess the risk of the patient, whether the patient is clinically deteriorating or not. If the patient is clinically getting worsened, obviously the patient has to come back to the hospital. And those patients who are belonging to the moderate set of moderate group, that is the patients who are suffering from some amount of breathlessness, and if there is a consolidatory patch or infiltrates on chest X-ray, such group of patients, or presence of any form of comorbidities, like if the patient is having underlying kidney disease or a cardiogenic or a cardiac disease, or if the patient is elderly, or any other form of comorbidities. So such group of patients with significant symptoms has to be mandatorily admitted in the hospital and kept under isolation room. And those patients who are having who are on ventilatory support, such group of patients belong to the critical care illness group. And regarding the management part, those patients who are falling to the moderate category, who are hospitalized in the isolation room, preferably it would be wise to start them with hydroxychloroquine. Regarding azithromycin, it is debatable that plus minus azithromycin. Plus, in certain institutions, they also tend to add oseltamivir. For the reason is that we have reports coming from different parts of the world that not all these infections are COVID-19. There could be a possibility of swine flu infection as well. So in such a condition, it would be wise to add oseltamivir along with your hydroxychloroquine and azithromycin. And next question would be regarding whether you would add an antiviral in such group of patients or not. Again, it is debatable. In certain institutions, they start antivirals also in this group of patients. And in certain hospitals, they delay the start of antivirals. But my personal opinion would be that, as well as I can quote the studies from MERS as well as MERS infection. There have been a lot of studies coming from there that preferably start your antivirals as early as possible rather than delaying it when the patient gets critically ill. And in terms of patients who are admitted in the ICU, and if you're suspecting, and if the patient is rapidly deteriorating, and if you're suspecting if there is a patient is suffering from a cytokine release syndrome, you have to send the inflammatory markers like IL-3, IL-6, and IL-8, and the TNF-alpha, and all those subsets can be assessed if it is available, and if it is significantly elevated, and you can add your anti-IL-6 molecule, that is tocilizumab, to reduce the inflammatory response. And also antivirals has to be started. So if your patient is in the ICU, the treatment modality would be that the patient should be continued on HCQ for a period of 5 days, plus azithromycin for 5 days, plus antivirals, whichever is available. In India, as till date, only lopinavir, ritonavir combination is available. I'm not sure regarding the availability of remdesivir, and plus tocilizumab if your patient has been suspected to be suffering from cytokine release syndrome. And continue the ventilatory support, as well as make sure that in certain institutions, they also add broad spectrum antibiotics also, just to give additional coverage. And if your patient is not improving or clinically deteriorating, make sure to rule out alternative diagnosis, as well as rule out ventilator-associated pneumonia. And so I feel this will be the standard modality of treatment for COVID-19 patients.
Thank you, sir. We'll just go for a couple of more questions. And if there are more questions, you can definitely answer them offline, and then I can put it with the YouTube link with the answers.
Can
so
I
the
just
next question?
add to what Tinku said? I mean, in Singapore, I think we would have a very similar approach to managing the COVID patients. The only thing that I would encourage clinicians to do is there is a big trial called the Solidarity Trial, which is being run out by the WHO. And on top of helping your own patients, if we can enroll the patients in this trial, and the trial encompasses all the drugs that Tinku mentioned. Then we can contribute to data, and we can actually in time be able to give future patients evidence-based options rather than hypothetical best guess options that are available at the moment.
One quick question, Dr. Dev, your comments on the usage of convalescent plasma, one thing which I missed.
One thing is it's not in the Solidarity trial, and there are challenges in actually getting the convalescent plasma. The best data for the convalescent plasma is that it uses the progression to ARDS. So most of the patients who have received this so far are usually in the intensive care setting.
Anyone can comment regarding the utility of BCG? I mean, there is an ongoing debate regarding whether BCG gives any form of protection.
I wish I could say something about it, but I can't. Sorry.
Actually, we have found some vaccine-like material can be used to induce the dendritic cell response. We use some nasal spray antigen ranging from mice substance. We think that because we use the substance to spray onto the nasal mucosa, we found that the ratio of non-specific immunoglobulin A can be increased, and also the nasal mucosa getting health better day by day. So we think that maybe BCG is one tool to induce improve the innate immunity. But I think more and more evidence needs to be gathered.
Thank you.
Okay.
Okay. Sir, we have already, it's about to be 9 and we have already 15 minutes past our schedule. I would request you all to please answer the requested questions by the attendees offline. Maybe I can, put in the answers given by you with the link of this current webinar session, recorded session of the webinar, and then maybe they can see their answers there. So once again, thank you so much for all the faculties to actually give us the valuable time, especially on the weekend, Saturday. And we highly appreciate your support, sir. Thank you so much.
Thank you.
Thank you.
Thank you.